Pulmonary embolism. The priority concept in this area is going to be gas exchange. And the gas exchange concept exemplar will be pulmonary embolism. Interrelated concepts will be perfusion and clotting. A pulmonary embolism with infarction is what's being shown in this picture. The embolism is not allowing oxygen to reach certain areas of the lung, so that becomes infarcted. Basically, it's without oxygen, so the tissue begins to die. With the pulmonary embolism, basically we have a collection of particulate matter, and this can be solids, liquids, or air, but most commonly it will be a blood clot that actually enters the venous circulation and then lodges in the pulmonary vessels. It will lodge in the pulmonary artery or one of the branches. Then platelets begin to collect on that embolus, and it triggers the release of substances that cause blood vessel constriction, which further impairs oxygenation to that area. Widespread pulmonary vessel constriction and pulmonary hypertension are going to impair gas exchange and tissue perfusion. So these blood clots usually come from a venous thromboembolism in the leg or the pelvic vein, and then it will break off and travel through the vena cava into the right side of the heart. These emboli are going to lead to reduced gas exchange, reduced oxygenation, pulmonary tissue hypoxia, decreased perfusion, and potential death. In other words, yes, people do die from pulmonary emboli. Potentially, it is the most common cause of preventable death in hospitalized clients. But due to symptoms that are often vague, it's often misdiagnosed. Risk factors for pulmonary embolus are prolonged immobilization, central venous catheters, surgery, obesity, advancing age, any condition that will increase blood clotting, and a client who has a history of thromboembolism. So, some of the things we could look at would be that immobility that causes stasis of the blood, or dehydration where the blood becomes more viscous, it's thicker, and now blood clots are more likely to form. The obesity where we have decreased mobility, surgery where we have decreased mobility, uh, taking some medications such as hormones, whether it is a female hormone or a male hormone, they do increase the risk of blood clotting. Some medications, such as oral contraceptives, can increase the risk of blood clotting, etc., etc., etc. So to help prevent the formation of blood clots and to promote health and wellness, we should always encourage the client to cease smoking. We should encourage weight reduction, increasing physical activity, especially after surgery, having that early ambulation or range of motion if the client does have mobility issues or position changes. We can do the sequential compression devices post-operatively to improve blood flow and circulation. Encourage the client not to cross the legs. If the client has an ongoing risk of venous thromboemboli, we can also surgically implant an inferior vena cava filter, and this will prevent those clots from reaching the heart. Avoiding the tight or constrictive clothing that could actually increase the risk of thromboemboli. Not putting pressure under the popliteal space. In other words, we're not going to put pillows behind the knees. If the client is traveling or sitting for long periods of time, we do encourage them to get up frequently, and we also encourage them to drink a lot of fluids. And if they begin to have symptoms of a thromboemboli, they should never massage or compress those leg muscles because that can encourage the breaking off of the clot that would then travel and become the embolus. So some of the symptoms these clients are going to have may not have the classic signs and symptoms, and this can often lead to PEs being overlooked. But some of these symptoms would include a sudden onset of dyspnea, that sudden sharp stabbing chest pain, apprehension and restlessness from hypoxia, feeling of impending doom, cough, hemoptysis, so coughing up the blood, diaphoresis, tachypnea, crackles in the lungs. Maybe we'll hear a pleural friction rub. The client will have tachycardia. If they have a fat embolism, which is another cause of a pulmonary emboli, they will have the petechiae over the chest. They are going to have decreased arterial oxygen saturation. And again, those symptoms are going to vary depending on the size and type of embolism. With respiratory, some of the symptoms we look at will be dyspnea, tachypnea, tachycardia, that pleuritic chest pain, maybe a dry cough, and of course the hemoptysis. Cardiac, we can see the distended neck veins, syncope, cyanosis, systemic hypotension, abnormal heart sounds, and or an abnormal ECG. And of course, hypoxemia can trigger anxiety and that sense of impending doom. We'll also do a lab assessment, and we'll be looking at the metabolic panel, troponin, a BNP, the D dimer. ABGs may show if there is respiratory alkalosis, and the FiO2 PaO2 ratio is going to begin to fall. Of course, we'll look at the pulse oximetry and do some imaging with a computed tomography pulmonary angiography, a magnetic resonance arteriography, the chest x-ray, which can diagnose other conditions, and the Doppler ultrasound that can actually diagnose the venous thrombosis. As far as analysis, the hypoxemia is going to be due to the mismatch of the lung perfusion and alveolar gas exchange with oxygenation. Hypotension will be due to inadequate circulation to the left ventricle. We do have that potential for excessive bleeding due to anticoagulation or fibrinolytic therapy, which causes inadequate clotting. And of course, anxiety due to that hypoxemia and life-threatening illness. So how do we treat a pulmonary embolus? These clients are most likely going to require oxygen therapy, which will include a nasal cannula or maybe a mask. They should be in a high Fowler's position, and we should do continuous patient monitoring, which will include telemetry, vital signs, the respiratory status at least every 30 minutes, which will include lung sounds, the rate and rhythm of the respirations, the skin color, cap refill, tracheal position. We should continuously monitor the cardiac status, getting blood pressures in both the right and left arms and comparing those, doing pulse quality, watching for dysrhythmias, and monitoring for neck vein distension. We need to obtain adequate venous access. We need good IV sites, and then we will initiate IV fluid therapy. We need to continuously monitor that pulse oximetry. And drug therapy. Drug therapy will consist of the fibrinolytics, so the TPA, to break down the clot or dissolve the clot, and we'll follow that with anticoagulants to help prevent further clot formation. We can do vasopressors if we have the systemic hypotension, such as norepinephrine, epinephrine, and dopamine. We can give medications to improve myocardial contractility, such as dobutamine, or vasodilators, such as nitroprusside. We should also assess for bleeding every 2 hours if we've done the fibrinolytics and or the anticoagulants, um, and initiate bleeding precautions. We should be examining all stool, urine, and drainage and vomitus for gross blood, testing for occult blood in those areas. And if we suspect abdominal bleeding, then measure the abdominal girth every 8 hours to determine if it is increasing. We should also monitor lab values and chest x-rays. Surgically, we can do an embolectomy and once again place that inferior vena cava filter. So we have a 65-year-old woman who's brought to the emergency department by her husband with new onset shortness of breath. She did have an abdominal hysterectomy 5 days ago, and her husband states that she has stayed in bed since she was discharged from her surgery 48 hours ago because she felt very short of breath whenever she got up. So what risk factors are present for the venous thromboembolism? Well, prolonged immobility. She is older, but I'm not going to say she's old. And she's had recent surgery. During triage, the following vital signs and assessments have been noted. Her temp is 99.6. Heart rate is 126, showing a sinus tachycardia. Her saturation is 84% on room air. She does have petechiae across the chest and in the axilla. Blood pressure is 80/44. Respiratory rate is 28 and labored, and we auscultate crackles bilaterally. So based on these findings, what do you suspect might be happening with this client? Well, since we're studying pulmonary embolism, I'm going to step out on a limb here and say that she has a pulmonary embolism. She could also have pneumonia based on her recent surgery and immobility, but a further assessment should be performed to ascertain the specifics of her symptoms. When the emergency department provider is notified of the client's manifestations, the client is moved immediately to a treatment room. The provider writes the following orders: O2 at 2 liters per nasal cannula, a stat CBC, BMP, D-dimer, APTT, and INR, a stat CT of the chest, start a saline lock. Which order will take priority at this time and why? Again, priority is going to be based on if I don't do this, something really bad could happen to my client. We start off with our ABCs, then we look at safety and change in level of consciousness as we try and order our interventions. So based on this client's pulse ox reading, the priority is going to be the oxygen. Next, we'll get that saline lock in because we may have to give some medications very quickly. We can also obtain our blood samples from the saline lock. And after those lab specimens have been sent, the radiology department can start the CT of the chest. While in the treatment room, the client says she needs to use the bathroom. The nurse delegates this task to the UAP. What is the best approach for the nursing assistant to take? Should the UAP place the client on a bedpan and stay with her until she's finished? Should the UAP ambulate her into the hall bathroom on room air and stand outside the door until she's done? Should the UAP ask the provider for an indwelling urinary catheter because of the shortness of breath with ambulation? Or should the UAP tell the client to try and wait until the shortness of breath subsides? Really, the best answer is going to be A. The nursing assistant should place the client on a bedpan and stay with her. She's too short of breath to ambulate to the bathroom, and she needs to remain on oxygen at all times, especially with that low SaO2. The nursing assistant should not ask the provider about an indwelling catheter because that only increases the possibility of a UTI. And the client should never be told to try and wait. That does increase the risk for a UTI, causing stasis of urine. 2 hours later, the client is admitted to the medical unit where she started on a continuous IV heparin weight-based protocol. What finding indicates that the heparin infusion is therapeutic? We have an INR less than 1. The INR is between 2 and 3. The APTT is the same as the control, or the APTT is 1.5 to 2.5 times the control. The correct answer is D. When a client is started on continuous heparin, the APTT is drawn before therapy is started, and then about every 4 hours until we reach that therapeutic range of 1.5 to 2.5 times the control. And after that, we can slow down the checking of the APTT. 3 days later, the provider prepares to discharge the client on warfarin. Which teaching points do you include about this therapy? Select all that apply. Is it be sure to have follow-up INR lab tests done? Yes, we definitely need to monitor what the INR rates are doing because that will dictate the dosage of the warfarin. Did the client report any bruising or bleeding to the provider? Yes, that indicates we have significant bleeding going on. Should the client consume lots of foods that are rich in vitamin K, such as green leafy vegetables? No. Vitamin K is the antidote for warfarin. So if they're consuming a great deal of foods that are high in vitamin A, they're increasing the risk of clotting. Should they use a soft toothbrush to brush their teeth and an electric razor to shave the legs? Yes. We want to minimize the risk of bleeding by taking away sharp objects. And should we tell the client a skin rash is expected while you're taking this drug? No. It's a sign of an adverse drug reaction and it needs to be reported to the provider. So which of these clients is going to be at the greatest risk of developing ARDS? Is it the 24-year-old male admitted with blunt chest trauma and aspiration? Is it the 56-year-old male with a history of alcohol abuse and chronic pancreatitis? Is it the 72-year-old male who is a post-heart valve surgery who's receiving 1 unit of packed red blood cells? Or is it the 82-year-old female on antibiotics for pneumonia? The correct answer is A. All of these clients actually will create a risk for ARDS, but the trauma client that has the direct chest injury and known aspiration is going to be at the greatest ARDS risk factor for developing ARDS. Um, the most common risk factor for ARDS is going to be sepsis. Other risk factors include bacteremia, that trauma with or without pulmonary contusion, multiple fractures, burns, massive transfusions, near drowning, post-perfusion injury after cardiopulmonary bypass surgery or CABG, pancreatitis, and fat embolism. A client is being discharged home on warfarin therapy to manage an acute pulmonary embolism. Which client response indicates a need for further teaching by the nurse? Is it, I should limit my alcohol consumption, I should eat more green leafy vegetables like spinach, I should take the medications at the same time every day, or I should make a doctor's appointment for weekly blood draws? Well, as we just discussed a little while ago, the correct answer will be B. Vitamin K is found in those dark green leafy vegetables like spinach, and that can interfere with the action of the warfarin. And now we have a client who's in acute respiratory failure, classified as having ventilatory failure. The nurse understands that which finding is a potential cause of ventilatory failure. Is it pulmonary edema, hypovolemic shock, pulmonary embolus, or opioid analgesic overdose? The correct answer is D. Acute ventilatory failure is the type of problem in oxygen intake and carbon dioxide removal, and then blood delivery. And it causes a ventilation perfusion mismatch in which that perfusion is normal, but the ventilation is inadequate. And it occurs when chest pressure does not change enough to permit air movement into and out of the lungs. As a result, too little oxygen reaches the alveoli and carbon dioxide is retained. If you think about it, opioid analgesic overdose is a respiratory depressant. The client has very little lung movement. It's depressed. So it is a very strong possibility or cause of ventilatory failure. The other choices listed are going to be related more to oxygenation failure.